You're listening to Med School Radio. Welcome back to Med School Radio. This is Simon in Tokyo. Listening to some music, and we're going to be going over some MCQs for the heart from Robbins Review. This is a great book if you'd like to review for the USMLE or for your medical school exams. So let's get right to it. Okay, we're going to be reading the first 5 here, so let's start with question number 1. An 82-year-old woman has had increasing fatigue for the past 2 years. During this time, she has experienced paroxysmal dizziness and syncope. On physical examination, she is afebrile. Her pulse is 44 times per minute, respirations are 16, and blood pressure is 100/65. On auscultation, the lungs are clear and no murmurs are heard. An echocardiogram shows a normal-sized heart with normal valve motion and estimated ejection fraction of 50%. After parasympathetic or vagal stimulation, the heart rate slows and becomes irregular. And an abnormality involving which of the following is most likely to be present in this patient? So here are the choices. We have the atrioventricular node, bundle of His, left bundle branch, parasympathetic ganglion, right bundle branch, sinoatrial node, or sympathetic ganglion. I'm going to read those again. Atrioventricular node, bundle of His, left bundle branch, parasympathetic ganglion, right bundle branch, sinoatrial node, or sympathetic ganglion. So remember that on auscultation, the lungs are clear, there are no murmurs, and the echo shows a normal-sized heart with normal valve motion. And the ejection fraction is about 50%. But she has increasing fatigue over the past 2 years. Now she's getting dizzy and even fainting. So, and with parasympathetic vagal stimulation, the heart rate slows and becomes irregular. So what's the problem here? So the answer here is the sinoatrial node. The pacemaker for the heart is the sinoatrial node, with a natural rhythm near 70 times per minute and a normal range of 60 times per minute to 100 times per minute. Other parts of the cardiac conduction system pass along this rate. And rates less than 60 are defined as bradycardia, and rates greater than 100 are defined as tachycardia. Bradyarrhythmias less than 50 times per minute suggest an SA node disorder. SA node dysfunction may worsen with cardioactive drugs such as cardiac glycosides, beta-adrenergic blockers, calcium channel blockers, and amiodarone. An increase in sinus rate results from increase in sympathetic tone acting via beta-adrenergic receptors, or a decrease in parasympathetic tone acting via muscarinic receptors, or both. And lastly, abnormalities involving the other listed options are unlikely to produce such a pronounced and consistent bradycardia. I think that case was very clear. So let's go on to the next one. Okay, now we have a neonate developing normally has a newborn checkup. On physical examination, there is a systolic murmur. An echocardiography reveals a muscular defect of the intraventricular septum. A checkup 30 years later fails to reveal either a murmur or a flow defect between the ventricles. Which of the following cells most likely proliferated and led to disappearance of the defect? So the choices here: adipocytes, conduction cells, endothelial cells, fibroblasts, mesothelial cells, or stem cells. So You can probably hear a baby in the background. That's the child upstairs. Wow, she's having a good one today. Okay. So the choices again. Adipocytes, conduction cells, endothelial cells, fibroblasts, mesothelial cells, or stem cells. Which of these cells most likely proliferated and led to disappearance of the defect in the intraventricular septum? So here's the answer. Native cardiac stem cells can proliferate and replace cardiac myocytes throughout life, but these stem cells are most active in neonates. They have the potential to respond to injury. Some ventricular septal defects do close during life. And research is ongoing regarding methods for inducing stem cell proliferation. Of the remaining cells listed, adipocytes enlarge with aging. Endothelial cells may proliferate to produce more coronary collateral channels in response to exercise training, and they can resurface vascular grafts. Fibroblasts respond to injury by producing collagenous scar tissue that reduces contractility. So the answer here is the stem cells, which can proliferate and replace the cardiac myocytes throughout life. And they are most active in neonates. So this is what's replacing the intraventricular septum problem here, the defect. Okay, so let's go to the next one. Okay, question 3. A 66-year-old man has a cough and worsening shortness of breath for 3 years. On examination, there is dullness to percussion at both lung bases and poorly audible breath sounds. On physical examination, pulse is 77, blood pressure is 110/80. He does not have agonal pain, and his liver span is increased to 14 centimeters. He has pitting edema in his knees, and jugular venous distension is noted to the angle of the jaw at 45-degree elevation of his head while lying down. Which of the following is the most likely causing his disease? So think about that for a second. I'm going to look up agonal pain. So agonal pain is talking about angina or chest pain. And we've learned about the different types of angina. But remember that angina is a discomfort caused when your heart muscle doesn't get enough oxygen-rich blood. And it feels like a pressure or squeezing on your chest. And I might do a separate one on angina because it's so detailed. Not in this podcast. So let's go on. You know what I do when I read these in the practices? I read them very slowly. And it's a funny thing. When you're reading them fast, you really forget what the first sentence says. And it's very important. I've heard, of course, that the last sentence is important. But the first sentence is extremely important. So I read the first sentence and I think about that. So let's look at this again. A 66-year-old man has had cough and worsening shortness of breath for 3 years. So he has angina. No, he does not have angina. And his liver span is increased to 14 centimeters. Pitting edema to his knees, and he has jugular venous distension. So the choices here: atrial myxoma, essential hypertension, hyperlipidemia, rheumatic fever, or smoking. Atrial myxoma, essential hypertension, hyperlipidemia, rheumatic fever, or smoking. What is causing his shortness of breath, the dullness to percussion on both lung bases, poorly audible sounds? Liver span is increased. He has no angina, pitting edema to his knees, and jugular venous distension. So this is smoking. These findings are consistent with right-sided congestive heart failure leading to peripheral edema, body cavity effusions, pleural effusions in this case, passive congestion of the liver, and jugular venous distension. Pure right-sided failure is less common than left-sided failure, and the former most often follows pulmonary disease, or cor pulmonale. So what is cor pulmonale? Cor pulmonale is, this is right-sided heart failure, and it is an enlargement of the right ventricle due to high blood pressure in the lungs, which is usually caused by chronic lung disease. So when you have cor pulmonale and right-sided heart failure, you would have fatigue, an increase in peripheral venous pressure. There could be ascites or an enlarged liver and spleen. And this may be secondary to chronic pulmonary problems. So, of course, as it is said in the words, distended jugular veins would be seen. There could be anorexia and complaints of GI distress, weight gain, and edema. So let's go back to the question here. So chronic obstructive pulmonary disease, or COPD, is more common than restrictive lung disease, and smoking leads to COPD. Atrial myxomas, which is one of the choice, which are uncommon and more often on the left side of the heart and may produce intermittent valvular obstruction. Essential hypertension is systemic and places a pressure load on the left side of the heart. Another of the choices, hyperlipidemia, is a risk factor for ischemic heart disease that is more likely to involve the left side of the heart. And finally, rheumatic heart disease may produce heart failure, but it is more often, left-sided. So that's another great question. I like how Robbins also writes the explanations to the questions in a way that teaches you the main points of the question. So then you see the other choices, when you get halfway through this question bank, you've really learned so much because a lot of this is repeated. Let's go on to the next one, number 4. A 62-year-old woman has had increasing dyspnea for the past 2 years. She now awakens at night with air hunger and cough productive of a frothy sputum. On examination, she has rales in all lung fields. Her point of maximal impulse is strong and displaced laterally. Echocardiography shows a decreased ejection fraction of 30% with concentric increase in left ventricular wall size. Lastly, the valves appear normal. So which of the underlying diseases does she have? So think about that case for a second. What is a healthy ejection fraction? In a healthy heart, each beat should pump out at least 50% of the blood in the left ventricle. So your ejection fraction should be between 50 to 75% to indicate the heart is pumping well and able to deliver an adequate supply of blood to the body and the brain. So in this case, remember, we have a 62-year-old woman. She has increasing dyspnea for the past 2 years, and she wakes up at night with air hunger and a cough with productive of frothy sputum. She's got rales in her lungs, and she has a decreased ejection fraction, 30%. So what's causing this? So here are the choices: amyloidosis, cardiomyopathy, hypertension, myocarditis, or pericarditis. Again, amyloidosis, cardiomyopathy, hypertension, myocarditis, or pericarditis. The answer here is hypertension. Left-sided congestive heart failure leads to pulmonary congestion and edema. Systemic hypertension is common and leads to pressure load with predominantly concentric left ventricular hypertrophy with systolic dysfunction. So let's go back to the question stem again, because it mentioned that. It said that her point of maximal impulse is strong and displaced laterally, and echocardiography shows the decreased ejection fraction of 30% with concentric increase in left ventricular wall size. So the other options listed are more likely to produce a diastolic dysfunction with a decrease of both right and left ventricular function. Okay, let's go on to the next question. Okay, the last one for today, question 5. A 41-year-old woman has been awakened at night with air hunger, again, for the past year. She notes sleeping better while sitting up in bed, and her serum B-type natriuretic peptide is greater than 400, which is very high. So what cardiac disease best explains her condition? She's waking up at night with air hunger for a year, and she says she sleeps better when she sits up in bed, and she has a high beta natriuretic peptide. So the first choice is Atrial Myxoma. Next, fibrinous pericarditis, giant cell myocarditis, Liebman-Sachs endocarditis, or last choice, rheumatic valvulitis. Once more, could it be atrial myxoma, fibrinous pericarditis, giant cell myocarditis, Liebman-Sachs endocarditis, or rheumatic valvulitis? The answer is rheumatic valvulitis. Paroxysmal nocturnal dyspnea is a feature of left-sided congestive heart failure, and rheumatic heart disease most often involves the mitral, aortic, or both valves, and left-sided valvular disease leads to pulmonary edema. While upright, pulmonary edema fluid is more concentrated at the lung bases, which helps improve breathing. And rheumatic heart disease was more common before antibiotic therapy for group A beta hemolytic streptococcal infections was available, and multiple bouts beginning in childhood led to valvular damage over decades. An atrial myxoma usually occurs on the left side of the heart, but the obstruction is often intermittent. Fibrinous pericarditis can produce chest pain, but the amount of accompanying fluid is often so small that cardiac function is not impaired. Giant cell myocarditis is a rare cause of cardiac failure, and Liebman-Sachs endocarditis is seen in systemic lupus erythematosus, and typically does not impair valvular or ventricular function. So the answer here was rheumatic valvulitis for this 41-year-old woman who has been waking up at night with air hunger for the past year. She sleeps better when she sits up, and she has a very high serum B-type natriuretic peptide. Okay, thanks for tuning in. I think we'll be back again with some more MCQs quite soon. So we'll see you next time.